Pauline Tully.
And I want to welcome the witnesses and thank them for presenting here today at our committee. I'd like to just maybe ask a few questions to Madeleine first, if that's okay, and to the Neurological Alliance of Ireland. You're just stating in that the neuro-rehabilitation strategy hasn't been implemented. In fact, only 2 of the teams have been partially established in the last 3 years. And you also say that there's 288 specialist beds are required. How many beds are there actually available at the moment? You say it's 50 in your statement, but then you mentioned 30. So, and just is that 30 additional beds or 50 additional beds? How many are there available in total? And why has this strategy, in your opinion, not been implemented? Is it a lack of funding, or is it a lack of suitably qualified personnel to staff the teams? Or can you expand on that, please?
Great question. I'll answer the first in relation to the existing number of beds. It's a little bit difficult to get a handle on the number of existing beds, to be honest, because there has been, the steering group itself for the implementation of the strategy has met so infrequently in terms of mapping what's existing and what's in place. We are aware that there are 120 beds in the National Rehabilitation Hospital. The redevelopment of the National Rehabilitation Hospital into effectively a new hospital did not, while very, very welcome and a fantastic facility, did not introduce any additional beds. We're aware there are beds in a Roscommon unit and beds recently brought on stream this year in Peamount. Again, very welcome developments. But to answer your question directly, we're finding it difficult to get a handle on exactly how many beds are in the system, especially of those 288 beds are in the system. We do know from the rehabilitation medicine programme in the last estimate that they gave that we are less than half of what we need to be in terms of specialist rehabilitation beds. And to answer your question as to why the strategy has not been implemented, we would see it really as a question of funding, that the repeated submissions are made to the estimate process each year for the funding of the strategy and also of the rehabilitation teams. And unfortunately, that funding has not been forthcoming. Just as to say, in relation to the demonstrator project, the teams in CHOs 6 and 7, that demonstrator project under the implementation framework, that is outlined in the disability capacity review this year as costing 5.2 million. There was only 2.6 million provided for that, for the establishment of a managed clinical network in community health organisations 6 and 7. So that's really little, only more than half of what's required to put that service in place. And as I said in our submission, that's the one development that there has been in the neuro-rehabilitation strategy. The addition of some inpatient beds in Peamount Hospital and the development of 2 implementation teams in CHOs and 6 and 7, none of which are on the ground yet.
Okay. Well, I think it's something that definitely this committee needs to support and to push for the implementation of, and I think that's something that we'd all be happy to do. Just to go to the National Federation of Voluntary Service Providers, I suppose my first question is about how do you envisage service provision changing in order to align with the UNCRPD? Because I think we have to acknowledge that, to move towards implementation and ratification of or full implementation of the UNCRPD, we have to promote independent and support independent living. And probably there's a need, for personalised budgets so that people have a choice on how they, how live all aspects of their lives. So I'm just wondering, like service provision at the moment, we would have had witnesses in here who would have talked about it and said about the difficulty they had in identifying a suitable placement for, say, example, a school leaver. That many of the facilities were, located in industrial estates and, did not look like educational facilities, didn't have the same facilities. And indeed, some services would be quite poor in that, I would have someone tell me that, their sibling had completed their Leaving Cert, sibling had Down syndrome, completed their Leaving Cert, and then in the service they were actually colouring in pictures, so they were regressing rather than progression. And also that many will say that maybe the service is provided, but it's almost one size fits all, it take it or leave it attitude. We know one size does not fit all, and it has to, accommodate all levels of need. I also note that you state that you've been in consultation on the new housing strategy, and you say your members have been in consultation. Can you just clarify, is that service users? Because disabled people and DPOs need to be involved if we're to implement the UNCRPD properly. So they need to be involved in the consultation again. And I'm just, the nothing with that about us without us concept. So I'm just wondering who you're referring to. And you also mentioned a collaborative approach undertaken by services together with the HSE during COVID. I just said many people felt totally abandoned by service providers and the HSE during COVID, especially in the first 6 months. I had many people saying that they just felt they had no support whatsoever. And indeed, they queried where the budget for their service user had gone in that time, because they certainly didn't receive any of it, and they would have had additional costs during that period of time. Okay, thank you.
Yeah. Okay, so in terms of the imagining and what services should look like in the future, I suppose in our opening statement we have acknowledged the really important lived experience that has been expressed, and we agree with you. There's nothing about us without us, and the primacy of the lived experience in the voice. And I suppose from the service provider perspective, which is the umbrella body that we represent, the need is there for multi-annual funding to allow planning to happen, because at the moment the options are so limited, because the only investment, if we take your first question first, which is around the residential and then moving into the day sports, the only options that have been funded in the last number of years have been the emergency crisis place. And typically they're delivered too late in a traumatic situation when somebody's primary carer, who's often an elderly parent, has passed away or has become very ill. And so people are being, if you imagine a series of steps of ladders, people are receiving full-time residential support at the most traumatic time of the journey that could happen, when actually if we could begin investing in multi-annual planning, which I know that some previous witnesses in previous debates have talked about, the predictability of the diagnosis that you have, allowing us to do that planning, then what you could be doing is investing in much more rights-based approaches, like the personal assistance, like the personal budgets, like the home support, and moving up those steps of ladder as appropriate, as required, and in line with the will and preference of the person. But that investment has not been available in the last number of years. All that has been available has been purely the crisis and emergency response, and that's not delivered in a way that allows the person transition into it, allows the person to develop their independent skills as a young adult or as an adult in their 20s or 30s who wishes to express the view that they wish to live outside the family home of origin. And so we're calling for the multi-annual approach to planning and budgeting and delivery of service provision that responds to the UNCRPD, responds to the ADM, and allows people to begin to express and develop their independence in how they live. In terms of then, you've just spoken about the one size fitting all in terms of day services, and again, I suppose our ambition is to move much beyond on that and to have, I suppose, a multi-layered approach, and there have been lots of very good initiatives that need to be further developed. For instance, there's been a wonderful series of transition planning developments where young people are approached 2 years before they leave school. If we look at the WALK programme, the peer programme, if we look at the Cumas New Ross ability programme, the outcomes from supporting young people at that early stage have been fantastic, and that's what needs to be developed and improved, and it needs a cross-departmental approach to that planning. And I suppose we would call for the inclusion of career guidance for young people in special schools, because without that we have very low ambitions that would suggest that the only option would be a full-time service, a day service placement, when actually what we should be looking at are the employment opportunities, the education opportunities for young people who attend special school. But we don't have career guidance counselling at the moment in those locations. So I suppose there's a listening and a very much an acknowledgement of the lived experience that has been expressed here. There's the openness on the part of service providers to develop in all of the ways that are described, and there's initiatives under the New Directions programme and under other initiatives that include things like the transition planning. I'll just briefly deal with the other two questions then. In terms of consultation on the housing strategy, there is, I suppose, we would like to complement the running of the consultation process for the new housing strategy. It has been the most inclusive process I've been involved in my time in the National Federation. It has involved surveys of people with lived experience on both the steering committee developing the programme and in the consultation rounds, which I know have taken place with DPOs. As a service provider umbrella body, we are involved in that steering committee alongside those organisations that represent people directly. And there is a very much holistic, collaborative approach to the development of the strategy, and I think it's probably a model that we would like to see replicated in future strategies. So it's very much inclusive of people with lived experience, inclusive of service providers, inclusive of all the real key stakeholders. In terms of the collaborative approach with the HSE during the time of COVID, when we look at the response that was required, there was an immediate response required to support people who live in residential services, many of whom, when the day services closed for public health reasons, who didn't normally reside within their residential place, needed to be supported 24 hours a day in their residential space because they weren't attending their day service. And this required the application of resources from the day service sector into the residential supports to allow that support be provided. When we examine the mortality and infection rates for people with a disability who had very significant risk factors at the beginning of the outbreak of COVID-19, the outcomes have been relatively, in comparison with other jurisdictions, much less. So there's been a very low level of infection, a very low level of mortality. That has come with an enormous price for families who experienced lesser support in the day service locations during the pandemic. So the experiences that you've described, we would fully acknowledge those, and we were fully in compassionate response to those families, but the resources that were required to ensure that there was a safe service provided in residential did have an impact on families, and we acknowledge that.